Hey guys, I just had an awesome conversation with Dr. Claude Steriade, who is an epileptologist at NYU. She gives the dish on like how to show up as a patient to create the best type of conversation and bridge the communication gap and questions that like are really good to ask our epileptologists. Also, she specializes in autoimmune epilepsy, and I don't know about y'all, but I did not know what that was until this conversation. Highly, highly recommend just checking this out and getting these tips from an epileptologist. It almost feels like being like on the other side of the curtain because we just get the inside scoop. Okay, I can't wait for y'all to hear this. Before we dive in, I want to give huge shout outs to community partners Epilepsy Foundation of America, the Danny Did Foundation, and Epilepsy Alliance America. And big thanks to sponsors Neurelis and SK Life Science. Thank you for believing in this podcast and to help keep it going. All right, y'all, pull up a seat. This is going to be good. Well, Dr. Claude Steriade, it is so awesome to have you here. Thank you so much for joining. What the F? And right out of the gate, I just want to start with this question because you're an epileptologist. And if you could magically input like one change of mindset in every epilepsy patient's brain, what would that change be that would like help with their epilepsy care? What would that change be?
Sure. Well, first of all, thanks for having me. I'm really excited to join you today. I think like the most important thing that I try to impart in my patients and that I would really hope for all of my patients to at some point acquire is like a sense of hope. I think there's a lot of people with epilepsy, statistically a third of people with epilepsy who still have seizures despite medications. Um, but I just had this conversation with someone yesterday. I was like, I think there's a drug somewhere out there for everybody. In your case, maybe the drug isn't on the shelf in a pharmacy yet. And in some patients, it's not a matter of the right drug, it's the matter of the right surgery or the right dietary approach or whatever it is that's going to fix their seizures. But I truly, truly think there is something out there for everyone. And it's just a matter of like not giving up and finding it and just sticking with it. And I think it's easy for me to say because I don't live with this every day. And I, only see my patients every, couple of months, sometimes more often, sometimes less, depending on how they're doing. So I have sort of like a different perspective, right? Because I'm not sort of in the thick of it. But I do feel like an immense amount of hope, that there is something out there for everybody. And if it's not out there, then it's going to be out there at some point, for, I think, every person.
So right off the bat, you're just gonna make me start crying because I love this so much. Because that personally applies to me, and that's like what I've just started doing is having hope because I did not know, and I think I only know this because I'm like so ingrained in the epilepsy community, but I didn't know how many new medications are on the horizon. I didn't know, how many alternative treatment options there are. Like I'm learning so much. And it's like, oh, so maybe one day, like my seizures will stop.
Yeah.
And I love that that's the goal for that's what you'd love for all of us to have is just a little bit of hope.
Yeah, yeah, I hope so. I hope that everybody can feel that, and you don't have to. I don't think it's reasonable to expect that anyone would feel this every day, It's normal to have like ups and downs. But I mean, I see this all the time in my clinic, like people who just didn't give up and, they did the next clinical trial or decided to go for that surgery or whatever it is that we ended up working through and, it finally worked for them. So I think it's okay to be patient with yourself and, be frustrated with the process because I can't imagine what it's like to go through everything that my patients and you and people with epilepsy go through. But I do think that like it's so exciting what's out there to try to find new treatments for epilepsy, and it's so we're so lucky to have so many options already available, and so I really think that it's important not to give up.
Yeah, thank you for that. That's awesome. Um, So you're an epileptologist at NYU's Comprehensive Epilepsy Center. No big deal. Um, I feel like that requires like dusting the shoulder off or something because
Just
that's
my
so
dream
dope.
job, just living my best
Why?
life.
Tell me about that. Why is it your dream job?
Well, I mean, I just work in the coolest place with the coolest people and the coolest city, and I have the greatest patients. Like my clinic is so cool because I have like New York City is just such a fun place, and you have people from all walks of the world and different backgrounds, and I just love my colleagues. I mean, I couldn't ask for anything better in a job, really. Like I just feel so lucky every day when I get to go to work and like do what I love and, get to hopefully help some people and, get to do something that's like also really, really interesting, like from like a selfish sort of, standpoint. But yeah, I'm really lucky.
That's not selfish. That's not selfish. You should always, I mean, everyone wants to do something that they find interesting, right? So, like,
Yeah, yeah. You're right. You're right.
how,
It's not selfish.
yeah, no, like, what's interesting about it to you?
So, I think, epilepsy is like a disorder where you really get a window into the mind that's really unique. I mean, all of neurology is fascinating to me. That's why I went into it. The brain is like what makes you you. It's what, makes us unique and different from like other species. Um,
Totally. Yeah.
but, in epilepsy, you sort of get like a glimpse into, the mind's sort of, complexities and, individualities. There are no two seizures that are the same. During seizures, sort of like someone's particular part of the brain really like comes to the forefront when it's, having a little seizure. And it's just like fascinating to
I love
see.
that. Just pops up.
Just, hello. Uh,
That part of the brain's saying hi
yeah, just saying
in a
hello,
very annoying way.
sometimes it goes a little haywire. Um, but yeah, it's fascinating to me just, hearing people's stories, what they experience when they're having seizures, what their journey has been like. And, from like a neuroscientific standpoint, I think what happens to the brain during seizures and what causes epilepsy in the first place is just really fascinating. And it's really rewarding as a physician to get to work in that field because I think it's really one of the parts of neurology when you can make really the biggest impact for patients and really help them. You may not fix the underlying problem. That's the case in most of medicine, actually, but you can really help someone live with the condition that affects every part of their lives.
Yeah. Wow. I feel your patients are very lucky. 100% to have you as a doctor. That's awesome.
So
Just the compassion and passion you have is just really beautiful and I love it. But you because we spoke earlier and you were telling me that you specialize and also it's like if you just Google, Dr. Claude Steriade, you'll find it, but you specialize in autoimmune epilepsy.
right.
Um, and that is something that when we talked, I was like, I don't know what that is. And you're like, oh my God, seriously? And I'm like, I know it's so bad. I don't know what it is. I don't. Um, and I should, but I trust you over Google to tell me, like at first I just kind of want to start with like, what is autoimmune epilepsy? And then like also what should, what are the signs of it, so that like if there's someone out here listening, feels like that resonates a little bit or something like that, just to kind of like get an idea of what else is out there because I know I felt very ignorant like when I was like, oh my God, this is the first time I'm hearing about this. And I'm guessing I'm not the only one.
Sure. Well, first of all, don't feel bad. I feel like you're not the only one, and there's, probably some physicians that only recently became aware of it because it's really like an emerging field. And that's kind of why I got into it. When I uh, finished my fellowship, there really seemed to be like this really exciting area within epilepsy that was still like fresh and where there were a lot of unanswered questions. And, what attracted me to it is, a lot of opportunities for like effective treatments potentially. And essentially, what it is this idea that's really only, come to the forefront in the past decade, I'd say, that in a small proportion of people with epilepsy, there's something autoimmune that triggered their epilepsy in the first place. And by autoimmune, I mean that, the body's immune system that's normally designed to fight off things that are foreign to it starts attacking the brain. And so the reason that this sort of got discovered is that there's this group of conditions called autoimmune encephalitis, which means, inflammation in the brain, that were discovered, in which seizures are often one of the symptoms, but usually go along with other types of symptoms, like someone becoming confused rather rapidly, developing new behavioral changes, changes to personality, other sort of mental health symptoms, sometimes other neurologic symptoms like involuntary movements. So there's this syndrome of autoimmune encephalitis that's often associated with antibodies that are targeting different proteins in the brain that are important to regulate sort of brain function, brain electrical currents. And what's now being realized is that some patients can have these antibodies, may not have like the full syndrome of autoimmune encephalitis. They may not have presented, with rapid confusion, with hard to control seizures, ended up in the hospital. They may simply have seizures that have been hard to control. And some of the things that go along with epilepsy that we're kind of used to seeing in the clinic, they may have memory problems, they may have noticed changes in their mood and their behavior. And in a small proportion of these patients, they can have these antibodies that target brain proteins. And so these antibodies have then caused inflammation in the brain that has then resulted in the seizures. And we're still not exactly 100% sure how often this happens, but probably the closest estimate we have that's as accurate as can be is that about 1 in 20 people with focal epilepsy of unknown cause, meaning their brain MRI hasn't shown a clear cause for it. There's no brain tumor, there's no, malformation of cortical development there from birth, there's no, cavernoma, group of abnormal blood vessels. None of
Sure.
the
Yeah,
usual
yeah, yeah.
causes that we think of with seizures are there. So if you test 1 in 20 people that have focal epilepsy of unknown cause, you can find one of these antibodies. And usually if you do find one of these antibodies, it's in someone that had adult onset of seizures that come from the temporal lobe. So they tend to stare off, have other things that we say with temporal lobe seizures, may smack their lips. Sometimes before they have a seizure, they may have, a feeling like they're reliving something from their past or have a feeling going into their chest. Sometimes they may get other kind of weird sensations like goosebumps on one side of their body, hear something that isn't there. So someone with adult onset temporal lobe seizures where you can't find the cause on their testing, on their brain MRI, and without a clear sort of risk factor for it, like it doesn't run in their family, they never had a head trauma, they never had seizures when they were babies. So, it's 1 in 20 isn't a huge number, but it's high enough that it's worth looking for. And the reason that I got interested in this is that if you can identify it early when there's still inflammation, then there's an opportunity to perhaps act on the underlying cause of seizures, which is really not something that we get to do much of in epilepsy. You know, almost all
Yeah.
of our treatments work no matter what the cause is. They work on the end result of epilepsy, which is that brain cells are hyperexcitable. There's too much electricity going on. And so most of our drugs, they work on reducing the amount of electricity in the brain. And so what attracted me to this field is, well, there's this opportunity to like find out why the seizures are happening and maybe even modifying what the underlying problem is.
I mean, that's huge. So I have so many questions. But I like when you were describing like all the different types of things that happen with focal epilepsy, and a lot of those I could relate to because that's what I have. But like and a lot of those things like like feeling like you've experienced something before or deja
Hmm.
vu or having goosebumps like only on one side,
Hmm.
or smacking your lips, all those things like it's so I think it's just the thing about focal epilepsy is that, like, it's so under-recognized that all like, those things can happen, and you could just feel like you're going crazy,
Yeah.
that you don't even realize you're having seizures,
Yeah.
and I think that's the experience for so many people. I am so fortunate in the sense where, like, like we're like 99% sure my epilepsy came from having brain surgery to remove a brain tumor, you know? And I've talked to so many folks who don't know where their epilepsy came from, and that can be a real struggle, you know, to not know, to not have that answer. And I think, like you said, it's 1 in 20, not a huge amount, but also definitely worth exploring. And I think, you know, maybe just getting that answer too could be really helpful. So you said, like, so it's a different type of treatment. What is the type of treatment, you know, rather than, like you said, like, you know, rather than just treating like seizures and trying to control electrical activity, what's the treatment for autoimmune
Sure.
epilepsy? How is it different?
So if you're able to diagnose someone in the earlier part of their illness, you know, usually within the first 2 years is ideally the time that it's best to diagnose this at, because that's when there's the most amount of inflammation. Then we use different types of treatments that essentially dampen the body's immune response. So there's different types of treatments for it, and we usually think of it as there's first line, second line, even third line of treatment, and it basically starts with medicines that dampen your immune system but are not super high risk in terms of immunosuppression. So you can imagine the main risk of those kinds of treatments is that if you're dampening your body's immune system, you're going to be at risk for infections. And then there's some of those specific immunotherapies come with a specific set of side effects for each of them. And then as you sort of go through that, you know, if that's the diagnosis that someone has, but they're early in their illness and they're not responding to that first line, you might move on to second or third line. And it's extremely individual based on how confident you are in the diagnosis in the first place. Did they have a specific antibody? Is there evidence that there's active autoimmunity in their brain? So we can assess that by doing different tests like a spinal tap or looking at their neuroimaging, and then
Okay.
seeing whether they're responding to immunotherapy. So just because something's autoimmune doesn't mean it's going to respond to autoimmune targeted treatments. That can depend on a lot of different things, the specific type of autoimmune problem that they have, because the immune system is extremely complex, just like the brain, how long they've had it. So, you know, let's say it's been 10 years and someone's just getting diagnosed now. It may be that the autoimmune problem has sort of burned itself out, and you know
Mm.
you're sort of dealing with the aftermath. And no matter how much you suppress someone's immune system, you can't really change the aftermath of an inflammatory problem, which is generally scar tissue that starts forming in the brain. So basically, with each person, you're trying to see, do they really have the problem? How far in are they at? Are they responding to autoimmune type treatments to sort of
Hmm.
gauge, like, is it worth it? What kind of benefit are you looking at? What are the risks?
Yeah. Wow. That, I mean, it's so funny because you said, you know, you're so fascinated with the brain because of how complex it is and all those things, you know, and it's like, and then you're like, and the immune system's complex too. I'm like, girl, you just like complex things, and I appreciate it. It's 'cause-
Well, it doesn't help that I have like the worst imposter syndrome, so I just like multiply it and I do it to myself.
no. Why? Why do you have imposter syndrome? See, it's an epidemic. Okay.
Because I'm a
How can you
person and I have
explain?
two X chromosomes. So,
There it is. There it is. That's,
yep.
you said it before I did. I was like, it's an it's an epidemic amongst women who have achieved things or not achieved things. It doesn't even
Not
matter. It's
enough.
just like this.
Not
Yeah,
enough
yeah.
achievements.
It's never enough. It's never enough. Oh my god. So okay, so you had mentioned in there that the testing for autoimmune, there's something about a spinal tap,
Hmm.
which, ow. But I'm, you know, if we're trying to get answers is necessary.
Hmm.
And then I think there's one other thing that I might have missed.
Yeah. So I usually start with a simple blood test before going to things like a spinal tap. So there's, you know, those antibodies that target different brain proteins that I was talking about earlier. You can test for those. It's commercially available. There's different labs in the US. I tend to send to one in particular that has a lot of sort of expertise in that, and
Awesome.
sort of,
I didn't know that was even a thing that you
yeah,
could like pick a lab to
you
send it to.
Yeah, I mean, the devil is in the
So cool.
details, actually, because when I
Yeah.
first joined NYU, you know, these panels, these antibody panels, were getting sent and sort of inconsistently to different places, to different panels were getting sent. So we sort of like
Oh.
harmonized it. We looked at all of the different panels that are getting tested, and others we've decided as a group which is the one that we want, where do we send it. So I think it's really important for the physicians to know which panel they're sending, who's doing
Mm-hmm.
it. Is it someone who has experience? Is it like a reputable lab? And is it testing for the right antibodies? Because again, like an antibody panel can mean a lot of different things, and you want to make sure that you're testing for the ones that tend to happen in people with epilepsy. And that's what I always like teach the neurology residents when I, give them my talk, is like really look at the details. When you get an antibody panel back, don't just put antibody panel negative or positive, whatever it is. Like actually look at the report and make sure it included the ones that you're interested in. And then, so that's sort of the first step.
Okay,
And
I have a
yeah.
question about that first step. Let's say someone, like someone asks their doctor for an antibiotic panel
Hmm.
or vice versa.
Yeah.
Is it obnoxious for a patient to be like, "Hey doc, can you make sure this is going to a proper lab?" Just because like I don't think all, epileptologists got training from you and learned that this is what you're supposed to do,
Yeah.
and that's not, I'm not trying to say anything bad about epileptologists. There's so much under the sun everyone needs to know.
Hmm.
So would that be like obnoxious if I was your patient and it was like, hey, Dr. Steriade,
Yeah.
are you making sure this is going to the right lab? Like, because sometimes we feel obnoxious with our questions, you
Oh,
know?
well, I don't think it's obnoxious. I think like the right question would be, where is my blood getting sent to? And is this a lab that has a lot of experience testing for these? And are they going to be double checking if there's a positive finding that it's really positive? That last one is probably the best way to check that it's a good lab, because the lab that I like to send to, there's sort of two layers of checks. They do like a first screening check where they take the patient's blood or spinal fluid, they put it on a rat brain slice, and they see if anything lights up. So to see if there's any sort of binding
Wow.
happening.
Yeah.
And then the second step is to take cells, make them express the target antigen that the antibody can bind to if it's there, to see if there's any binding happening. So there's two steps, and a good lab should do those two steps. So I
Okay.
don't think it's up to a patient to get into the weeds of those things, because that's,
Sure.
hard for any patient to sort of wrap their brains around. It's hard for many physicians in training to wrap their brains around. But I think asking, if your blood is getting sent to a reference lab where they're going to be double checking with two different methods whether those antibodies are present, is like a good way to sort of get at whether it's the right kind of place.
Awesome. I love that. And it's also like I thank you for providing that, because I feel like that's something you go into an appointment with and it takes away the obnoxious part. And I only say that because like you never I know I think most patients don't ever want to appear like we're like checking on our doctors or like,
Mm.
trying to, you know what I mean? We just want to be like, but there's this thing and I just want to make sure this is happening.
Yeah.
And like that I feel like that just bridges the gap in communication
I don't think
right
it's
there.
ever wrong to ask a question. I mean, you may ask, should I be getting this panel? And then your doctor may say, actually, we know from your MRI that your seizures come from that small area of abnormality that I think is a focal cortical dysplasia. And I am constantly surprised. I feel like I try hard to communicate with my patients and share knowledge with them. And I'm always surprised by, the failures in the communication that have happened and things that I thought they knew because I've been following them for years. And it turns out they didn't realize that when we first got their MRI, this thing happened. So if anything, it's an opportunity to revisit things that, maybe you need to communicate more with your doctor about, in terms of why it is that you have seizures. So, worst case scenario, this is what happens. Your doctor is going to say, well, actually, you don't need this test because I do know why your seizures happen. In which case, that's great. If you didn't realize that was the case, that's a problem, and you should be having this conversation with your doctor again.
Yeah. Oh, that's awesome. That's awesome because again, it just feels very attainable, a very approachable way to say something where, it's like just never wanting to cause offense or anything. And this is just checking boxes and just like double checking and getting all the information.
Sure. Yeah. No, I don't think I would
Yeah.
ever be offended with a patient asking me that question.
Well,
So.
Yeah. No, I mean, I feel I would hope it would impress most doctors to be like, "Whoa, where
Yeah.
did you get this?" Like,
I'd be like, wow, you're such
like,
a smart patient. There,
yeah.
there.
This was not on Google.
This is not ChatGPT. Actually, I don't know if ChatGPT would come up with that on, a Swish search. Like, what test should I get if I have seizures from my temporal lobes and doctors can't figure out where it's coming from? I wonder if ChatGPT would figure it out.
Yeah. We should go find out.
Yeah.
Um, so okay, when you are, because I know not all of your patients have autoimmune
Mhm.
epilepsy. Um, and I think when we talked before, you said like it was kind of like 50-50. So what are the, I guess like my question is like, what are the similarities and differences in like how seizures present,
Mhm.
or treatment options?
Yeah.
I know we had talked about things that would be like added autoimmune therapies, but I guess I'm just curious, like similarities and differences between like your patients that have autoimmune epilepsy and your patients that don't.
Sure, sure. So, I mean, it depends on the kind of autoimmune problem, just to like add a layer of complexity, the type of antibody that they have, and all of that. But I
Girl,
think
you love that complexity, and I love it for you. Okay.
I would say that, I have some autoimmune patients where I get the reward of following them, after I've treated them and they've done really great, and they're no longer having seizures or they're having rare seizures and they may still have some
Hmm.
memory issues, but they're overall doing well. And those are usually patients who have certain types of antibodies that target the surface of a cell. And those patients tend to do really well with immunotherapy if you identify them early and treat them early. And then I have other patients that have chronic seizures where they may have an antibody that targets the inside of a cell, and those are patients that tend to not respond as well to immunotherapies, or patients who don't have a clear antibody, but we think still that there's something autoimmune going on because their spinal tap showed something or their imaging showed something that was suspicious. And
Hmm.
unfortunately, some of those patients don't do as well, particularly if they're in the early stage and they haven't been treated yet. And I would say that like on my autoimmune days, patients are having oftentimes more seizures. They're more prone to clusters of seizures, prolonged
Hmm.
seizures. They may present to the hospital more frequently with seizure exacerbations or worsening in their other symptoms, like they may have worsening of their cognitive issues or, new behavioral symptoms. They're more prone to sort of behavioral side effects from a lot of the drugs we use to control seizures. So it's definitely like more complex days, and it really depends where I'm meeting someone at their journey, whether it's at the beginning or whether they've been treated. And I would say like
Hmm.
I have a combination of like really rewarding clinic visits where I feel like, oh, I really did good here, and clinic visits that are like tough, and I feel like we really got to get better treatments for people with autoimmune epilepsy, be able to find them earlier in their course, before they get scar tissue. Um, I would say my pure epilepsy days without autoimmune is like a mix. I have some patients that I follow and they're like, I call them social visits. I'm like refilling their meds, but we're really just catching up on, life. And it's like really nice and refreshing. And like I feel good at the end of it. Hopefully they do too. And then
That's
there's like
awesome. I
some,
love it.
yeah, they, and, in institution, that's like an aside, like in healthcare now, there's a lot of issues with like access to like physicians and wait times and, a lot of push
Yeah.
like using or like incorporating physician assistants or nurse practitioners. And that's where it's perceived to be like a place where like maybe patients can transition to nurse practitioners and physician assistants. But I don't want that. I want to keep seeing my well-controlled patients. Like I want to reap the rewards of what I
Oh
did.
yeah. Yes.
I don't
Yes.
want to
100%.
I don't want to pass my patients on to anybody else. This is nice. This is a good part of my day. Anyway, that's
Yes.
like
Yeah.
my parenthesis. Um, anyway, not
I
that you
love
get
it.
Ps and NPs. There's like wonderful, extremely well
No.
trained, but like,
No,
please
you're
don't
just
take my
like,
well
this is
controlled patients
mine.
away.
Yes. Yes. This is mine.
Anyway, so it's a mix of that, and unfortunately, about a third of people are drug resistant. I probably see more in my practice because I work, in a referral center. And yeah, there's a lot. I have some days where everybody's doing well and other days that are, harder. But I think there's always something that you can do and at least give a little bit of hope, if even if there isn't something that you're going to change that very day for that person, make a change that day. So yeah.
Yeah, I guess, and that leads to like my next question, just because it's like when I'm talking to an epileptologist, I feel like I'm getting like the inside scoop, you know, because it's like we get to like um I don't know, the gap in communication sometimes can be hard, and
Yeah.
not with just some of the things you mentioned, but also like sometimes, as I was saying before, sometimes being a patient is just like nerve wracking, no matter how much you love your doctor, just trying to like get things across. And it's like, well, what should I be saying? And so, what I want to know is what do you see as like, as a patient, that we
Hmm.
could do to help bridge this gap in communication? Um, and like, just a way to kind of show up prepared for our appointments, I guess, and the way that you think would be effective.
Yeah. So I, first of all, love it when patients show up with a seizure diary. There's nothing I love more, even if it's empty, even better if it's empty.
Oh, wow. Yeah, that would be nice.
Yeah. But
I just got it. I thought you meant like, oh, they like, cause like, like, oh, they didn't keep track, or no, they just seizure diary and there's no seizures.
that
Yes.
that's you don't have to do that. If you're having no seizures, that's fine. But
Yeah.
I just love it when patients come and it's either printed or it's in their phone, and everything things have been sort of digested already instead of us trying to work backwards, because it's really hard for people to remember if they've had seizures and when that's happened. So coming prepared with seizure diary and any sort of changes to treatments that have happened. Now with my chart in a lot of places, there's a lot of things that we do in between visits, not even just with my chart, with phone calls. And it can be hard for me when I'm in clinic to remember, okay, like a month ago, you called and you had a seizure, so we went up on X med by X amount. Like, I physically, when I'm looking at your chart, I have to go in and hunt through different encounters, and I'll get there, but it's so much easier for me if my patient comes and says, remember, this happened, I had that breakthrough, and then we up that med, and this is how I've been doing since then. Or I started getting dizzy, and then I contacted you, and then we went down. I feel bad asking patients to repeat to me something that's already happened between us, but it helps me a lot to sort of like get a review over everything that we've
Yeah.
already interacted about since our last visit. So
I
that
feel like
helps me a
that
lot.
seems normal, you know?
I, yeah,
Yeah, I feel like that's just like something like that would be, I don't know. Like, to me, it makes a lot of sense because it's like you guys have so many patients, like how are you supposed to keep track of all of this? And then it just gets everyone on the same page right
yeah.
off the bat.
And it
Yeah,
oftentimes, like, I feel like patients also realize, like, if they haven't come with that information and they backtrack, they're like, oh, actually, this happened. So I think it's always good because as you're preparing for
sure.
this, I think you're going to think
I know
of
I've done that.
questions, right? Like,
Yeah.
it's sort of like it frames how you think you're doing, what questions you may
Mhm.
have, like, is it the right thing that I'm on this dose of this med, or that we've done this? Because actually, in retrospect, like, I don't think I've been adjusting that well. So I think, like, sort of just taking 10 minutes to just like reflect and see, like, how do I think I've been doing since I last saw my doctor? How are my seizures? How am I tolerating my meds? And then I personally love it when patients come with a list of questions. I like it when we sort of have like a more organic discussion first, because a lot of the time, just in having that discussion that, we are going to have anyway, it's going to go through all of the questions that the person had. So they'll like then go on their list. And so actually, we talked about most of this, but I think it's good to have that because I feel like it's so frequent if you don't have something written down that someone says, I knew I wanted to ask you something, but I forget it now. And then I'm sure it always hits them when they're in a parking lot. So I think like coming prepared in that way is always really helpful. And I think doctors appreciate it when you come prepared with questions and with data in the reverse order.
Okay. Yeah. Data,
Data
questions,
first, then
go.
questions.
Yes. Yes. That's so funny because I do have like a medical notebook, a medical journal that I
Yeah.
keep, and I had to do a physical one because I always felt bad pulling out my phone, like because I just felt like it looked like I was like looking on Instagram or something. So I was like, no, like, so
Yeah.
I just have like a physical journal where I pull out and I've got the questions ahead of time.
Yeah.
And my epileptologist, who I absolutely love, she goes, okay, this is my favorite part. What are your questions? Like,
It's
this
like
is why I love you.
dessert.
Yeah.
What's for dessert today?
Yeah. Okay, so we got come in with data, questions, um, anything like for follow-up,
Yeah.
like that we should be aware of.
So I think it's always important to ask, like, as you're leaving, when should I be seeing you again? I
Mm.
feel like I mean, I'm sure I'm not the only one. Like my schedule is kind of tough, and it's always best to like make a plan of action. Like, when am I going to see you again? Also, a lot of the time we're like making a change because something is not going quite right. Someone's having seizures, someone's not tolerating. So, and this is maybe just me, but I usually tell people, like, do you mind just sending me a little note in X amount of weeks just to let me know that this, whatever we decided to do, has worked, or let me know if it hasn't. Because usually what we'll be doing in clinic is making a plan A, but then if plan A doesn't work, this is what we'll do, like plan B or C. And it's good to sort of like troubleshoot in advance and then have like a specific plan, because then it's super easy. And I feel like probably, I would imagine, a big part of the anxiety and the worry that comes with having epilepsy is the uncertainty, right? And I
Mm-hmm.
think, like,
Yeah.
whenever you have a plan, even if you don't know whether it's going to work or not, I think that
Mm-hmm.
eases a lot of that anxiety, because otherwise you're not left feeling like, oh, if this doesn't work, then what? So I think it helps patients' anxiety. It helps my anxiety too, also.
Oh, good.
Uh, it's not about me, but if it were. Uh,
No, I love that. I mean, for me, I didn't become a planner until I developed epilepsy.
yeah,
So, like, if you're giving me a plan and then like a backup plan, I am stoked. I love that. And I feel like that gives a little sense of relief and like being like,
yeah,
okay, so this is what happens if it doesn't work.
yeah,
It again, I feel like it's this theme, it adds to that hope.
yeah,
There's another option,
yeah.
there's something else.
There's always something else that you can do. And I tell people, like, I am not getting married to this plan that I'm giving you. Like,
Yeah.
if I am, we could always get divorced. Uh, like, some new information may arise that
Yes.
makes us make change plan B that we made to a different plan B. But I think it's always good to have some sort of starting point, and you're allowed to like change it together based on like new information. But I think it helps everybody sort of feel a little bit more calm about the whole
Yeah.
situation.
Okay, one more question that I have selfishly, I'm going to ask. And it's a little selfish, but it's also like for the community because I feel like this is something that um there's still so much like not misinformation, but just like conflicting
Yeah,
information. So I just want to get your opinion on like a rescue med. Where are we moving, I guess, is the right
right.
question
So
with rescue meds.
I think that's a question that used to be harder to answer because we didn't have a lot of, easily administered rescue medication. So then we used to have like rectal options or oral options where you kind of worry about the whole choking thing. So now that we have more options, have intranasal options that make it a lot easier to administer, we have like the freedom to like talk a little bit more about this, and more patients want to take this. And I would say that if anyone is prone to having seizures, there needs to be some sort of rescue plan in place, because, it's the minute that you think everything is going well and you decide you don't need to have a contingency plan, that, like the forces out there are going to decide to, throw a wrench into things. So it's always good to have a plan. And I always tell people, like, you're gonna have this and you're never gonna use it, but you're gonna feel so good when you're looking at it on your little, bedside drawer or in your purse, because you're gonna know that you have like a little security blanket. Um,
Oh, I love that.
so, you don't put a
Yeah.
rescue plan in place thinking you're gonna use it. Of course, you're not gonna use it because we're doing all the things to make sure that your epilepsy comes under the best
Right.
control. But life is full of uncertainties, and you may, travel, forget to take your meds. You may get sick. You may things.
Done that.
Life is
Done
full.
that.
Yes,
Yep.
yes. Glad you're
Or just
traveling.
tried to
Not
have
glad you're getting
fun.
sick. You know.
My yeah, no, my cousin always makes this joke. She's like, when I have a seizure, she's like, "Oh, did you try and have fun?" I was like, "Yes, I did.
That's
My mistake.
horrible.
Shouldn't have done it. Shouldn't have done it."
That'll teach you.
Yeah.
More fun for you.
How
You'll
how
get to have
dare you?
fun. Oh my God.
Yeah.
So yeah, so in terms of like what does a rescue plan look like, just like everybody's seizure is different. I think everybody's rescue plan should probably be individualized to some degree. There's like a starting point, which to me is any seizure that lasts more than 3 minutes. It used to be that we would wait until 5 minutes, but we now know that statistically speaking, if you're still having a seizure at 3 minutes, it's more likely than not to end up being 5 minutes, so why wait? So usually any
Mhm.
seizure that's more than 3 minutes or two or more seizures in 8 hours is sort of where I start from, especially when I first meet someone. They were recently diagnosed, or I'm just prescribing this for the first time. I don't really know their pattern very well yet. They may not know their own pattern very well yet. And then that's sort of like the starting point, and then you fine tune from there. There's some people that have frequent seizures, unfortunately. They have seizures every day sometimes. So you're not going to want to use a rescue if you have two in 8 hours, if that's your baseline. So you're going to want to adapt it to what's a change from your baseline. Another situation is I have a lot of patients who get auras before they lose awareness and go into a full blown seizure. And thankfully, their aura is long enough. And if that doesn't happen often, meaning it doesn't happen more than once a week, then I might tell them, okay, use the spray or whatever rescue medication we're using right at the onset of your aura to hopefully prevent you going into a full blown seizure where you're going to be losing awareness.
Wow.
And for a
Mhm.
lot of people, that does work. So there's a lot of fine
That's very
tuning
cool.
and like individualizing to someone's pattern. You do want to make sure you're not overusing rescue because there are benzodiazepines, and if you use it too often, it starts losing its efficacy. But as long as you're using it judiciously, no more than the intended number of times per month, and you're using it at the right time, then you're going to prevent hospitalizations, you're going to prevent injuries from seizures, and most importantly, you give people a little bit of control back over their life, which is again what I think is the main thing that we're trying to do when we're treating epilepsy.
Yeah, totally. Well, and I think, just personally, like I know I have that luxury of having an aura that can last a little bit longer where I can take a rescue med and it has a stop. Maybe the aura was just going to happen and nothing else was, right?
Yeah,
We don't know. But I do know that I had this aura and then did not have the full blown
right.
seizure to follow multiple times with the rescue med. So like I feel very fortunate in that sense. And I think then it's like to a certain extent, because my postictal phase is like 4 days of just not being able to do anything,
Yeah,
so I've gotten like those 4 days back,
that's
so it
huge.
can be like a huge, yeah.
Yeah,
So but I appreciate you saying, how individualized it is, which I think is just, the theme of epilepsy. It's like,
yeah,
it's so individual,
right. There are no two epilepsies the same. There's no two anti-seizure medication regimens exactly the same. There's no two rescue plans
Mhm.
exactly the same.
Yeah. Yeah. Which is like, it's like oddly comforting because then you can like be like, okay, well, that worked for someone else, it didn't work for me, but
Hmm.
that means we tailor it differently. Right. And
Yeah,
also simultaneously frustrating because you're like, but that worked for them. So why
yeah,
isn't it working for me?
yeah. But I mean, as a physician, and this is not comforting as a patient, but as a physician, this is kind of what attracted me to practicing epilepsy in the first place, is
Mm.
that I really did not like algorithmic medicine. You like have this little flow chart and you go down it, and if this happens and you do this and that. Like in epilepsy, there is no flow chart.
Sure.
There's no single right thing to do. This is it, there's a true
No.
art to it, and there's never a single right or a wrong answer. I mean, there's like drugs you should not use with certain epilepsy syndromes. There are wrong decisions,
Right.
but it's very much like an individual decision making that you're making with somebody, and I think that process is extremely rewarding.
Hmm.
And that's like what being a doctor is about. you know?
Yeah.
Yeah.
Yeah. Meeting that individual
Yeah.
patient where
Yeah.
they're at. Wow. You're an amazing doctor. And thank you so much for this conversation. I appreciate you and for all the work you do. I mean, you are just amazing. Um, but before we wrap up, I'm going to ask you 3 questions that have nothing to do with what we've been talking about.
Ah, okay,
Don't
shoot.
get nervous. They're not too bad. Number 1, what's your favorite color?
Red.
Oh, I'm wearing red. It's like I planned it just for
Perfect.
you.
It's meant to be.
Yes. Okay. Number 2, if you could go anywhere for like a month and time and money are no factors, there's no limits, where would you go?
Oh, I'd go back home to Montreal with my kids. Yeah. Yeah, I wish
Oh,
I could
that's
get a
so
month to like
sweet.
go to back home for a month.
Yeah.
It's like
Yeah,
not a super
you deserve
exciting
it.
answer, but that's kind of like in this phase of my life where I
No,
am
it's so
right
sweet
now, this is
though.
what I want to do.
Yeah.
Yeah.
Yeah, I don't blame you. That sounds, yeah,
Yeah, my
that
mom is there
going
and it's
home.
just such a great city. It's just the best.
Yeah.
I miss it.
I say yeah like I know. I've heard. I've
You should
seen.
definitely I'll send you
I
my
need to go.
little pro tips. Yeah. There's such great food
Yes.
and it's
That would be
Montreal
dope.
is like I mean, I love New York. New York is the center of the universe. I'm kidding. I love living here, but also like I feel like Montreal has like this mix of, it has everything that's cool about a big city. There's like culture and great
Yeah.
food and great things to see, like, but also like people are just so happy and relaxed, which is
Oh, well,
not,
that's different than New
yeah,
York.
that's a little different. Like it's got like the best of both, worlds. It's like a series of circumstances that led me to be here. I love living here, but like whenever I go back home, I'm like, this is, there's no place like this.
That's awesome.
Yeah.
You're like a Montreal spokesperson
I
then.
am. Definitely tourism. They should hire me. I would definitely do all the campaigns. Yeah.
I mean, I'm convinced. I'm ready to come
Yeah.
tomorrow. So
Do it. Book that flight.
well, maybe not tomorrow, but I
Okay.
will book that
All
flight.
right.
And then the last question is what does it mean to you to be a friend?
Oh, I think, to be a good friend, you're there for someone like thick and thin. I think it's loyalty is what it
Mm,
means to be a good
yeah.
friend. Yeah, I just had
Yeah.
that conversation with someone actually recently. She was like, my mother said that you're a loyal person. And I was like, man, I think that means that she thinks we're good friends because I think that's what loyalty is. And that's what friendship is, just like sticking with each
Yeah.
other no matter what, you know? Yeah.
Totally. Oh, I love that. Yeah. Well, Claude, thank you so much for this awesome, candid conversation, kind of like behind the scenes
Yeah.
ness of epileptologists. I really appreciate you and all your work, and this conversation is just amazing. So thank you.
This was really nice. Thanks for having me. I really
Of
enjoyed
course.
this.